Well, thank you, Andre, and thank you everyone for coming tonight. It's really, I'm enormously grateful and enormously excited about what has happened so far today. Having Mr. Picard chair the event and be a host for us is such a great honor. Having a Minister of Health who has those things to say is a surprise after some dry periods in this country. This is very encouraging. And I'm really excited to hear Louise speak for the first time, and Sir Michael I've had an opportunity to see a few times, and I know that we're in for a real treat. C'était aussi vraiment un grand plaisir de faire votre connaissance, Madame Bégin. Really an enormous honor. I also want to put out a welcome to the President of the Canadian Federation of Nurses Unions, Linda Silas, who's here with us today. Nurses are such an important partner in addressing the social determinants of health, and the CFNU and SUN have been great supporters of Upstream in this event, so thank you for that support. When I'm not organizing conferences like this, as Andre said, I have a day job, and I work at an inner city clinic in Saskatoon, which for some of you who are from big places might think that inner city and Saskatoon don't really go together. But unfortunately, the reality is we're big enough and divided enough as a city that we do have a segment of the population, a segment of the city that's very marginalized. And that's where I live and that's where I work. And the patients that I see tend to have the problems that go along with living in poverty. Diabetes, heart disease, depression, substance abuse. In our particular circumstance, HIV. We have triple the national average of new cases of HIV in our neighborhood. And at our clinic alone, we have over 400 cases in a small clinic of people living with HIV now. So usually what I do when I talk about the issues we're talking about today, I start with a story to ground us in that reality. Start with a story maybe of somebody who's struggling with their diabetes because of food insecurity, or struggling to manage their antiretroviral medications because they're in unstable housing. I was thinking about, who am I going to talk about today? I looked back in my chart and I thought, well, what's the diagnosis that I really see the most? At the end of the day, what's on my day sheet? And I realized that there was one note that was on my day sheet more often than anything else. And it's not exactly a diagnosis, but it's the end of the visit, no-show. And I started reflecting on that. No-show because I think some of the people who haven't followed up on their appointments recently, a 13-year-old girl who was having troubles at home, that her school counselor noticed that she was depressed and starting to have some cutting behavior, and so brought her in to see me. A young woman whose husband had a reasonably good job, but his wages were being garnished due to previous debt. So they had enough money coming in that they didn't qualify for drug coverage, but they didn't have enough, they weren't able to keep enough money that she could actually afford the anxiety medications that she needed. Or a young couple from a city not far from Saskatoon who'd come to town looking for support because the oil boom had made jobs disappear in their community, and as things got harder for them, they wound up going to fentanyl, which has become a real problem in our communities, as a balm to their troubles, and now we're wanting help with their addictions. And when somebody comes in a situation like that, in a state of crisis, I'm lucky. I work in you would probably know it as a CHC, a community health center type clinic, and so we have all kinds of disciplines. I can call the addictions counselor, outreach worker, the psychiatrist that comes every week or two. We have an emergency medication fund if people are in trouble. We mobilize everything, and we take time. We sit down with people for a long time when they're in a crisis. And most importantly, before they leave the room with me, I've already booked them in for their next appointment because I don't want to lose them after that crisis. I want to connect with them and see how we can help with the next step. But then so often, that next visit comes along and they're not there. You know, there's all kinds of reasons that could be. Maybe they thought I was a jerk and didn't want to see me again. Very possible. Or, maybe they got better. That could have happened. But, when when I think about it more, and when I think about the people who do eventually come back after missing a couple of appointments, they don't say that things got better or they didn't like the care. They really just had life get in the way. They were having troubles with transportation or with money or with where they were staying, that something changed, that they couldn't deal with that clinic appointment at that particular time. And the reality is, if we want to help people in that situation, if we want a health system that works better, if we want better health for the people in my community, we're going to need to look at the conditions in which they live. And that's what we've been talking about all day. And we've been hearing some fantastic things. We've been hearing great ideas of potential social interventions. Things like basic income, greater investment in early childhood development, housing first chez soi, all of these things that either are being done in small scale and could be increased or are new innovations. And these are great. But we face some limitations when we actually talk about implementing. And some of those limitations are due to the frames, the terms of argument, the way that we discuss political issues at the current time. Frames like economic growth being the most important thing rather than a tool to improve our well-being. Things like the idea of these sorts of interventions being costs rather than investments in ourselves and ultimately in the economy. Those frames limit us. Now, I have some hope, and the speeches I've heard all day today, including from the minister this evening, give me hope that there is an opportunity, there's room to shift the frame. And you know what? I already think we have a frame waiting for us. And this is what I've been saying through Upstream and the Healthy Society book for some time, is that health is a frame that's ready for us to start using. It's something we all care about already across political lines. We care about our own health, that of our neighbors, that of society at large. And when you look at elections, the issues that matter most to Canadians, healthcare is always up there, very top issue. Of course, we've established very well today that healthcare is not health, but it's a good surrogate for how important health is in our lives, that's the issue we care most about in political polling. And when you think about it, if you take that definition from the World Health Organization of health being not just the absence of illness, but full physical, social, and mental well-being, hard to imagine a better motto for a society for what you'd want to achieve than full physical, social, and mental well-being for the people, for the citizens, for the people in the country, the province, wherever you are. So we've got this frame, this destination, and our understanding of the social determinants of health gives us the roadmap to reach that destination. It's clear that by investing in better income distribution, housing, food security, etc., we can improve the health of our society. How do we take it the rest of the way? How do we finally make the shift so that that's our dominant frame? Well, I think there's a couple of ways. And part of this is why we're having this event tonight and having this connection with you and having Sir Michael Marmot here. Of course, there's the work that he's done in establishing our understanding of the social determinants of health, in leading the WHO Commission on the Social Determinants of Health that so clearly established what the areas of action need to be, and also just called out how serious the problem is that inequities are killing on a grand scale. That makes it stark and serious. But he also said something that has really informed our thinking, which is that what we need is a social movement based on evidence to address inequalities in health. And Madame Bégin said to me earlier today, she doesn't know if there's a social movement yet, but she thinks it might be the start of it. Vous avez dit quelque chose de même. Maybe lost in translation slightly. But this speaks to me because when we talk about Upstream, what we describe it as is a movement to build a healthy society through people-centered, evidence-based ideas. And when I first started going around the country talking about this idea, I sort of felt shy to say it's a movement. How can it be a movement? We're just a startup. But the reality is that we're not the movement. The movement is out there. The number of people who are thinking this way, demanding this kind of thinking and action is growing all the time. And we're simply in a position to name that and help to guide and stoke the flames. And that's what we're working on. And that's what tonight is about, is taking that movement to the next level. And we'll continue to do that the way we have been, working with experts across the country to gather the evidence on what are the key policy levers that could actually improve social determinants of health, and working with artists, writers to tell the story of those options, connect both with the head and the heart in order to really reach out to a wider community, individuals and organizations across the country who are starting to think along these lines, and maybe engage in campaigns of Upstream, or more importantly, integrate this language and this thinking into their own work as it starts to spread out and become that common frame. So that's a big part of it, is that social movement. But the second part is, in order to do the heavy lifting, you need the structures and resources within government to actually shift policy. It's when you have that top-down and bottom-up pressure that you can actually get past the inertia of current systems and see real change. And what's often been seen as the holy grail of that idea is the notion of health in all policies. And we heard that quote from the minister tonight, that the social determinants of health are the business of the entire government. We always hear people concerned that the health is taking up more and more of the budget. Health is already 100% of the budget. We just don't think about it that way. And if we did think about it that way, then we'd start to say, okay, then it's the decisions made in justice, in environment, in education, and finance. Those decisions need to go through the lens of, how is what we're proposing to do or not do going to improve or worsen the health of the population? And we talk to each other across silos, and we make plans to actually take the decisions that are going to improve health overall. And this has been done in Finland, in South Australia, and a number of places, in Quebec to a certain degree, across the world, and there have been some great learnings on this. And as we were preparing tonight and having some discussion with Sir Michael and reading his book, The Health Gap, which I highly recommend, I realized that health in all policies, as it tends to be articulated, has a couple of weaknesses that are important to address. One of those weaknesses is that it doesn't always think about equity, that you can improve health overall and actually widen the difference between certain populations. If you have, for example, improvements in education, or a program for accessing a new service, and you roll that out without giving any consideration to how it'll affect the most marginalized, the people who are ready, the people who are already doing well, will take the most advantage of that program, naturally, and that can actually exacerbate the differences rather than closing the gap, which is what we're trying to do. The second issue is that it's often done in a reactive fashion. When a new policy is being developed, or there's a new strategy for mental health, or a new development being built, then a health impact assessment or even a health equity impact assessment might take place. But that's still just reacting. It's kind of analogous to the upstream story. You're acting downstream, but there's all this work, this ongoing work of every department, ongoing work of government that isn't being analyzed or viewed through that lens of the opportunities to achieve greater health equity. And so in the preparation for this evening, we also prepared a document. I hope most of you had a chance to pick this up. If you didn't, there should be copies on the table on the way out. And this is the Health Equity Action Lens. And this is the document coming out of tonight's discussion, and we hope that it will spark ongoing discussion. And really, it's a paper describing a different approach, the HEAL approach, in which we enhance equity and catalyze policy change. It's really trying to fulfill the promise of health in all policies by taking it to the next level. And of course, this is still, it's a couple pages. It's pretty high level. There needs to be a great deal more detail, and it'll look different at different levels of government and at different times in history. But it's a real opportunity, and an opportunity for, if a government were to take this on, to show some real leadership, international leadership in addressing health equity in a serious way. Probably pretty good for them politically, thinking about how much people care about health, but much more importantly, enormous potential for impact, cracking that tough nut that so many countries have tried to do of addressing health inequities by doing it in a system-wide, focused way. And it is, as I say, it's high level, and And at times it can feel pretty far from the bedside, far from why I went into medicine to be having these kind of discussions. But in a couple of days, I'll be back in clinic. And when the new prenatal that I started on methadone a few days earlier doesn't show up, and I'm calling outreach to see if we can track her down and help her out, because clearly she's in a difficult spot, my mind's going to drift back here and remember that the only way we're going to make a real difference in people's health at the level of my community and across the country is if we have a systematic, system-wide approach with health as the primary goal. So with that, I thank you for joining us tonight. I hope that this, certainly not a first step, but hopefully a big step for moving this conversation forward in Canada, for making that dream of healthier people, whether it's in my neighborhood or across the country or in other places in the world, a reality, allowing us to really close that gap by taking strong action for health equity. And I also just want to end with an invitation. Upstream is not a closed shop. We would love for you to, share the story of tonight, share what you learned from all the speakers tonight, and encourage others to participate in the conversation around action for health equity, and to share your stories with us. This is what we do. We collect the stories of people across Canada who are seeing the downstream effects of bad decisions or the possibilities of good ones, and use those to reach out to a wider group as we build that social movement that Sir Michael has called for, based on evidence, with a lightning focus on addressing health inequities. Thanks very much. Have a good night.